Thank you. It's great to be here today, and I want to welcome you again to Nashville since I'm another hometown girl. And my husband works in the tourism industry, so we're especially glad for all of you people from out of town. But we are really excited to be here. I've been fortunate to be a part of the spasmodic dysphonia community, for over 22 years. I started working at Vanderbilt, more than that, years ago as a student, and Dr. Garrett was brand new at that point. And it was about 5-6 years after Dr. Nashville had given the first injection there at Vanderbilt. And we were still learning, everybody was learning, the doctors were learning, there was lots of research going on. And the speech pathologists at Vanderbilt are part of that team. There's doctors, speech pathologists, nurses, everybody in the house. They like to say kind of like sports medicine, but for the voice. And so I had that advantage. 75% of what I know about spasmodic dysphonia came at the knees of Dr. Ed Stone, Dr. Netterville, Dr. Corey, Dr. Garrett, and probably Christy Ludlow, Cheryl Volante, some people who were doing research at that time as well. The other 25% has come from the many, 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 many patients with SD that I have gotten to meet and talk to over the years. When I was at Vanderbilt, I had 2 new patients a week that I was over screening and talking to them, what we call pre-Botox counseling. I left Vanderbilt 13 years ago when my first child was born, which is hard to believe that it's been 13 years. Anyway, but my now teenager came along and I decided to stay home. It didn't last very long because there's not many of us out there who are voice therapists. And now I work part-time, but I still see probably, last year I saw 16 new Botox patients. Everything that I saw for the first time, a few of them knew they had it and they came to me. Some of them did not. And I think that this year I've already had 6. And I got 1 new one yesterday across the fax machine. So that'll be in the next couple weeks. So I still get the opportunity to talk to new patients and steer them and hopefully counsel them through kind of this journey that many of you have been on as people who've been diagnosed with this disorder or family members of those who've come along. So I'm going to talk a little bit about the speech pathologist role in spasmodic dysphonia. We are the less medical, treatment option and all but heavily involved in this treatment. Now, I will tell you I was in California, in Malibu, this week at being a part of a conference there, and I flew home and thought I'd make my PowerPoint slides, and I was on the only non-Wi-Fi enabled plane I think left. Anyway, so there's no pictures, no videos, no nothing exciting. And I told my family last night when I got in, my daughter said, "I can handle this, Mom. I can make this exciting." So she has added animation. Leave it to a 13-year-old. So all the flying and zooming and all that is all due to the fact that I hadn't spent time with my 13-year-old this week while I was gone, so we did it last night. So the first part that we play a role in, like I said, is evaluation a lot of times. Speech pathologists are not really supposed to diagnose, medical disorders and give a diagnosis. Most of the time, my referrals will come from an ENT. Occasionally they'll come from other physicians, neurologists, allergy, asthma, rare occasion, I'll get somebody from other, other types of physicians, but most of the time they come from an ENT. The thing about ear, nose, and throat doctors is they're not all like Dr. Francis, Dr. Garrett, and Dr. Burke, Most of them are general ENTs. A lot of them don't want to go for that extra year of specialization fellowship, or they've already been through many, many, many years of training. And so they do a little bit of a lot of things. They do the ears, nose, and throat. Because the disorder of spasmodic dysphonia is so rare, many of them may have never seen anyone with spasmodic dysphonia in their entire life, even with their 9 years of training that they already have. If they go to a specialty voice center to become a voice specialist, laryngologist, they'll actually get to hopefully see more of that, especially if it's treated there. Whenever I came into Vanderbilt, of course, we were having clinics every week. There were lots of patients coming through. So I had the benefit of getting to hear all of those voices. But even then, sometimes the doctors have questions, and they'll go, "Oh, we don't know. What is this?" Go spend some more time with the speech pathologist, because they don't have an hour and a half to spend talking to you, hearing the whole story and doing all that. So they send them to us, and that's good because we've got an hour or more that we can do. I had a physician, or a doctor, that was one of my neurology professors in school who said, speech pathologists, we don't have all the fancy equipment all the time. The doctors get all the fancy equipment, they get to look at the anatomy and physiology of things, and they are trained to look and see the problem. And that is true. As speech pathologists, we don't have all that fancy equipment very much, so we're trained to listen and figure out the problem. So a lot of times that comes to my advantage when it comes to diagnosing or working with and deciding if someone has spasmodic dysphonia. That neurology professor said we have the golden cochlea. That is our instrument that we can use to diagnose, because that ear is very valuable. And in spasmodic dysphonia, unless you've heard it before, you probably don't know what it is. All right? Most of the patients out there who've been diagnosed are probably some of our best diagnosticians out there, because they've heard it, they've lived it, they know it, and they might run into somebody on the streets and know what they have. I have been in a wedding reception line where I was behind someone who has spasmodic dysphonia and didn't know it, till of course I felt the need to ask them if they knew what they had. And I was at a conference leading worship in Houston, Texas, and met someone who had spasmodic dysphonia. They already knew, they'd already been to Dr. Stasny, already treated. And then we were at a restaurant in Destin, Florida one time, when the waiter came to the table behind us before coming to our table and said, "Are you ready to take your order?" And I was like, ding, 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 ding. And my husband looked at me and went, "You're going to tell me what's wrong, aren't you?" And if I can get my husband diagnosing it, then I feel like I've won. There's someone else on the bandwagon. But anyway, I think that those types of things, you have to heard it a lot of times. So you can't blame, those of you who've been to 10 doctors and spent 9 years to get a correct diagnosis, you cannot blame the fact that your first doctor did not get it right, and that you had to wait so long, because most likely he'd never heard it. And it really is difficult on that side. I usually tell everybody, though, go back and tell all those doctors that didn't know that you saw, because it may help someone else who comes down the pike in the future to be able to diagnose them and get them the help and get them treated a little bit sooner. The part of the evaluation then that as a speech pathologist we go into initially is sometimes differential diagnosis. A lot of the ENTs that send people to me will diagnose them with muscle tension dysphonia, and then I get the advantage of hearing them on the phone first whenever I schedule their appointment. And that, of course, everybody who has it knows they're worse on the phone, right? So that makes it easier for me because I get to hear them first. And so a lot of times I know before they even show up. I'm kind of thinking this, I'll do some more probing, but I kind of already got that spasmodic dysphonia on the radar. Then, we can spend some time. We can try some things with therapy if we want. Usually within a pretty short time, there are some differential diagnosis things that we look for in history, how the disorder comes on, what they can and cannot do, things like that we can kind of tell the difference between those two things. In some people who are stereotypical textbook people, it's very easy. There's a few that we have to kind of go, well, let's try a little bit of therapy and see how it goes. And then sometimes we relax them down and it becomes even more obvious, that the spasms are there and they're sound specific. So that is definitely a big part of the evaluation, and why I think the ENTs refer to speech pathologists. I was talking to someone earlier who said, she went to speech therapy and it got worse over the year, and sometimes you'll see an ENT and it'll be too early in your process with spasmodic dysphonia. It's too soon after the disorder has started, and it's not bad enough yet where we can really even determine things. And then 6 months later, you might see someone else, and it's very clear at that time too. So sometimes it depends on timing. But we can be a part of figuring that out. The biggest part for me with spasmodic dysphonia is, as a speech pathologist, is I do a lot of education. Once again, the doctors don't have all the time in the world to spend, and I think we found at Vanderbilt especially that if the patients were educated a lot ahead of time, they did so much better with the treatment. They handled it emotionally, physically, everything better if they knew what to expect, if they knew what was going on. And part of that is also just understanding the disorder. We can explain the disorder, we can explain the treatment options, Usually I go through all of the treatment options, the 4 options that Dr. Francis mentioned earlier in detail and talk about, you're going to read about, you're going to hear about all these different options, what the pros and cons are of each of those options out there, which ones I would recommend my family members to do, and as a speech pathologist, of course, I would love to say, and I can fix you with voice therapy, but I can't, unfortunately, do that. And so I have to, give them my honest opinion of all of the treatment options out there. The bigger part of that too is people have lots of questions, about side effects. They have lots of questions about long-term, things like that. And so we'll usually go through some of that, and then I'll tell them, based on what treatment they are going to choose, to go back and talk to their referring physician or the physician that they're going to see if they're going to pursue some sort of medical treatment option about some of those things as well. But we go through the treatment options pretty thoroughly and what to expect. A lot of people, I have to also say now, here's some websites you can read off the internet. Don't believe everything you read on the internet. Everybody knows that at heart, but it's really hard, especially when you have a rare disorder. People prey on that. People promise things. People can say all kinds of things because you're desperate and you want to be fixed. And so I kind of have to do some cautionary things too about everything you read. I always send them to the NSDA website, certain large medical centers that talk about spasmodic dysphonia particularly. And we talk about the referral network. The NSDA website's great because it's got all these providers listed. We talk about who they can go see, who knows more about this than others, if they want different treatment options out there. And who can give them support. I always give everybody the local support group. There are many of them out there, and if you don't know, they are on the website. But we give them the support group person. Jill and Gwen and people in this room have been contacts for all of my new patients that I send them to, so they can talk to somebody else who has been through it, And I think that's important. The family members often come, I find, with spasmodic dysphonia patients because they are just as desperate to find out why their family member is having difficulty communicating as the patient is themselves. They want to be able to help them if they can. And because they struggle to watch them communicate, they want to try and talk for them. They want to make it easier. And so a lot of times those family members will come along too. They have questions. They want to know. If it's a child with a parent, they want to know if they're going to get it too. Is it genetic? All those kind of questions. So I think that's a good place for speech pathology. There's a good one. That's really special. Of course, voice therapy is a part of what we do. I will have to admit right up front, though, it's not a huge part for spasmodic dysphonia. Okay, it is a important component, but not a huge part. In voice therapy for spasmodic dysphonia specifically, we cannot help the patient get normal voice. I cannot cure spasmodic dysphonia. With my behavioral treatment, I cannot treat your neurologic disorder and change the messages from your brain and tell them to do something different, unfortunately. I've been doing voice therapy only for 22 years, and I'm pretty good at what I do. So if you had something I could fix, I would be happy to fix you. But unfortunately, I have to confess up front that I don't have a great fix for this, okay? We can help people kind of work around the brakes. How many in the room have abductor, abductor, spasmodic dysphonia? Okay, we got a few, good. All right, and how about adductor? Yes, always the majority, but good, okay. How many of you have had Botox? Okay. A lot of times we can work with people that work abductor, especially since the Botox, as we know, is not as effectively treated with that. We can work them around the brakes. I had a patient one time who worked for an airline that no longer exists called Comair. And she was a stewardess and had to say that constantly, whenever she was on the microphone. And if it comes out every time, thank you for flying Comair. That's a little bit disturbing as a person standing up speaking in front of lots of people. So we taught her to say something closer to a G because it sounded like Comair. People thought they were hearing Comair, but the G didn't break because it wasn't a voiceless consonant. So she could say, thank you for flying Comair. And people thought it was Comair. We can work around things with high occurring words, phrases, sounds, things like that. If there's certain names that you always avoid, we might be able to make that easier. We can teach you to use things that you already know you can do. When new patients come to me and they didn't know what they had, and I say, well, this is what I believe you have. It's called spasmodic dysphonia, which basically means spasms causing bad voice. You could have told me that's what you had. They can always tell me. They also can tell me that they can whisper really good. They can talk at a high pitch really good. Some of them will say, I can talk with a foreign accent, and it goes away. They all have their little tricks and things that they can do. And we know those things change the messages from the brain and how the body perceives that communication path. And so we can use those things in therapy. People who want to try therapy, I'll usually commit to 2 visits. Because I say, I can't fix you, I can't ethically see you week after week after week. But I'll see you today, I'll send you home for 2 weeks, I'll see you again, we'll reevaluate. Because usually I'm just teaching them ways to work around it, all right? If I can get them closer to that breathier voice, if they can use more air, things like that, then they can turn on their Marilyn Monroe voice, then they don't spasm as badly. It's not effective for males as it is for females, but talking at a high pitch is also not so great for males. So it's a good thing more females are affected. We have more options for you. But the talking at a higher pitch sometimes can help in certain situations. I remember being at an SD support group meeting when Jill and all of them were there, and they talked about going through the drive-through that they thought they would be funny, and everybody go through an order together. So that's spasmodic dysphonia. That was one of those torture places, that they all hated but would love to do as a group. Anyway, and I have told countless people, if you go to the drive-through, you're on the, on the phone, certain things. If you just talk a little bit higher pitch, you might come across a little bit clearer and not break as badly. The other thing we can do is we can talk about just voice use in general. A lot of people have to use their voice every day for their job, for their family, things like that, and having it strain and strangle and stop and catch and spasm affects communication effectiveness. And like anybody with a voice problem, if we pace the muscle use out, take a break here and there, if we don't try and talk as loud, if we kind of monitor and pace our voice use just in the way that we treat any other muscle in the body, we tend to do a little better. Life gets a little easier, So we'd spend some time talking about that, of how we can make life just easier in general for voice use. There are some massage things that you can do for the tension. I've got some of that written in the handout that we'll look at everything, but there's some massage. You can start right underneath the base of your chin, basically, in your base of your tongue, and do some massage back there. The base of the tongue likes to get tight. You can move back and go right above the cartilages where they inject between. And massage the base of that tongue and kind of the upper laryngeal muscle area, and sometimes that helps, especially when it starts getting really tight and really strangly. And we can get rid of some compensation. Some people that I've seen have had this for years. They've been dealing with this for years and years and years, and they've developed some weird compensatory habits to work around it, and so they actually put more effort in to talk than they even need to. And it makes them wear out. It makes them wear out faster. It makes them frustrated. It makes them not want to talk, things like that. So if we work on getting rid of some of that compensation, that often helps as well. The vocal cords do not like to be squeezed that much. And if you've already got spasms and then you squeeze on top of it, it just makes them a little bit more frustrated. So, and it doesn't make you feel comfortable. So we can work on that. We also can do therapy to help improve the benefit, we should say, from other treatment options. After surgeries, after Botox injections, some people won't quite get all the way to normal. You saw Dr. Francis's numbers where it was like 80-something%. They felt like they were at about that maximum and optimal improvement. But we can do some therapy sometimes to get rid of that compensation that they've been doing beforehand, and usually that helps. They'll get another percentage more. If we do therapy beforehand, sometimes it helps a little bit, but it actually works better after the other treatments. And especially people who have to use their voice all the time. Occasionally it makes the benefit last a little bit longer, or seem to last longer for those patients, because their voice is a little more stable, a little bit easier, and so it makes the spasms less disruptive to them as they start to return after they've done Botox or something like that. Last thing that we can do as speech pathologists, which is unfortunately what I spend a lot of time doing, is being an advocate for the population. Unfortunately, battling insurance issues is at the top of that list, but I'm going to move it to the bottom because that is my least favorite thing to do in the world. When I first started dealing with spasmodic dysphonia patients, we had to write insurance letters explaining this was not cosmetic, this was for medical reasons, and they would approve it, it was fine, but there was a lot of letters that I wrote in those days. Now, we just have to fight for anything, I mean, it's just a fight, as we all know. It's issues, and so sometimes that happens. There's lots of appeals, but we guide the patient family through the decisions. I have patients all the time who will say, okay, I'm going to think about it for a while, and then they'll come back and ask more questions, or they'll come back and say, I'm going to try this treatment now, and then we'll start on that road, and then I'll check back with them, and so we kind of go through different modes, and we kind of guide them through. There's a time and readiness place for everything, and so we work with that. I've written letters for human resources, for jobs and people before, so that they could maybe have another break here and there because it wears them out to talk, or for people to understand after they have this injection, they're going to be a little weak for a week or two maybe, and so that their HR department knows and can work with them on the things that they need to be able to implement in their workplace. There is research. Speech pathologists historically do a lot of research. Christy Ludlow. My claim to fame for the research for spasmodic dysphonia is that I once held a rat while Dr. Vellante was injecting it with the other type of Botox that they have to see if it would last as long as the current type that we were using. And she found out that it did not, so we do not currently use it. We use the one that we've been using. That's my only claim to fame in research. Other than, I think I started that spreadsheet that Dr. Francis showed all those numbers for the patients. But for 2.5 years, I asked people, what happened when this started? And all that, and we kept all that data going. And so, but there's a lot of research being done, and speech pathologists, because they can do some listening and some different objective testing measures and things, they often are a part of that. That's just not my fault. We also check up on the patient, and we monitor their care and results of treatment. Some places will have diaries, some places you call in. My patients, I have call me whenever after they've been and had Botox or something so I can hear their normal voice. I had one call me a month ago, the day after her first injection, and she was all excited because she was in that window where if you're awake and it's swinging, the pendulum is swinging through over to the weaker breathier side, you got really good voice for a little period of time there. And she was so excited. I was like, just hold on, it may drift away, but it's going to come back, It's going to be good. And so I think, it's important for somebody to be following up on patients and to be there if they have questions or something doesn't act right after a certain treatment, for them to encourage them to go back. It's hard as a patient to go back and talk to your doctor about something sometimes. It's hard to get a hold of them sometimes. It's also hard to go back and question anything when you think this person knows what they're doing, they're the expert, I don't want to question anything. So sometimes it's easier to go to the speech pathologist, and that's great. I'm not going to answer questions right now because we're a little behind. I'm going to let Dr. Burke do his research, and then we'll answer questions on the panel.